Welcome, my dear students, to the class on chronic inflammatory bowel disease. An update. This is from Recent Advances 23. Whenever I say recent advance, we should accept that it has been authored by an expert or a panel of experts who have exclusively done a lot of work on that particular topic or series. Hence, there is no point in trying to outbeat them. Have this in mind. I shall be revisiting you on the mode of handling the recent advances. Roger Fickens and Neil Shepard are the authors for this particular article. These are the references that you people should go to. And this will be the mode of questions. Going on to the introduction, whether it is Robbins or Ackerman, whatsoever, all accept that it is a spectrum, the inflammatory bowel disease, ranging from Crohn's disease to ulcerative colitis or vice versa. These are two extremes of a spectrum, and it is not equivocal pathology. In the sense, it is one is not equal to the other. Also, the term indeterminate, which was introduced when neither features were there, has been deplored but accepted. So these are certain controversial terms which have come to stay and which we should have in mind when we are reporting pathologies. People say that pathology is ultimate and biopsy is definite. But then there are many diagnostic issues, that is what the authors say, as well as management issues. And though histology is concerned to be a gold standard, you find that there is an entire panel of investigations and detail to be borne in mind. Similarly, the complications for many of these diseases are dissimilar. Do not irrevocably append, that is, depend on it. This might be inappropriate. There are many mimics of this chronic inflammatory bowel disease, which I shall try to cover in this presentation. It has been advised that we should be diligent to exclude infective colitis, diverticulitis. And he says that there should be a correlation between the clinical presentation, the endoscopic picture, the gross in case of resections, and imaging. Biopsy, of course, shall be an important but a small piece of evidence. Do not try to over-depend on this, circumventing all these details. This is a picture for a recollection. We shall go to the details of it later on. Now, this is an intestinal section wherein I am finding villi. Villus is a projection above the surface. And there are also crypts, which are burrows below the surface. And when it comes to the crypts, you find that they are made up of a lot of these immature cells, which we shall be revisiting again. Having said that, they do mature after some time and become the columnar epithelium or the goblet cells, after which case you find that dysplasia or a malignant transformation is highly unlikely. Coming to the difference between a chronic inflammatory bowel disease and infection. Though in biopsies they say pathology is basic, you find that there are certain predictors, or you find that precedents which should be borne in mind when we give a diagnosis of chronic inflammatory bowel disease. These include basal plasmacytosis, increase in the plasma cells at the basal layer or the region of the crypts. Architectural changes, which we shall again be seeing. Crypt atrophy, distortion of the villus. They are more than equal to chronic inflammatory bowel disease. Granuloma in a case of Crohn's disease, and intraepithelial neoplasm in a case of ulcerative colitis. Crypt abscess, of course, is considered to be a prototype, but as I had warned you earlier, this alone might not be adequate. Hence, an overall picture is needed. What the author says is also, these pictures vary according to the period. When the patient comes, when he presents, and when the biopsy was taken. There is a term called a Paneth cell metaplasia that also should be borne in mind, and we should look for them. What about the granuloma and chronic inflammatory bowel disease? What is the differential diagnosis? These include cryptolytic granuloma. Around the crypt abscess, there can be a granuloma formation. Lymphocytic rosary, which is again indicative of inflammatory and not chronic inflammatory bowel disease. Diverticulitis, enterocolitis, cryptitis, and tuberculosis. So these should be borne in mind. In spite of all this, we do consider that granuloma is supposed to be a prototype of Crohn's disease. But what is the difference? Let us have it in one corner of our mind. We shall be seeing them again. So you find that continuing the dialogue in the earlier slide, you find that the overall picture is very much needed. Multiple sites of biopsy is mandatory. Note this down, you will have to write it. And accurate interpretation is impossible with the biopsy alone. Our differences are the real treasures. It can be difference in the tissue, difference in the diagnosis, or between personalities. Robbins I always mention as one of the books that we should lean upon. The same thing is applicable to any of the surgical pathology text. This particular article deals more with the gross and the microscopy, the morphological differences rather than the etiopathogenesis or the clinical presentations. In which case, these are the keywords. Always think of the subheading. The subheading will take you to the answer. I have not gone to divulge the details over here, but this we shall be seeing. What is the criteria? Is the disease in continuity, rectum involved, terminal ileum? What about the mucosa, serosa, creeping fat fistula, so on and so forth? This you people shall memorize. Always in a column like this, try to memorize the left column. And the others shall fall in place, provided we have read it. And invariably you would have read, you would have taken classes, you would have revised and narrated. I'll tell you the secret of handling the recent advances in my next class. So these are the macroscopic differences which you shall bear in mind. Whenever I say macroscopic differences, there has to be a microscopic difference also. So these are beautiful pictures thanks to web pathology, and I am seeing an entire carpet of pseudopolyps. We should be able to differentiate between a polyp and a pseudopolyp. A polyp is after all an outgrowth above the surface. A pseudopolyp, on the contrary, whenever there is an ulceration or a breakdown in the mucosa, the rest of it is left behind as a tag, which can be mistaken for a polyp. Ulcerative colitis by itself is known to predispose to malignancy. But then you find that pseudopolyps do not. Compare my statement with the previous diagram. I told you that the superficial cells will not lead to malignant transformation. It will be the deeper cells in the crypt. So this is the pseudopolyp. On this side, I find that there is a thinned out, and you find that it has been ravaged by trauma. And obviously, there is no mucosa at all that is left. Classical of ulcerative colitis. There is no skip lesion, and it shall be in continuity. There shall be a backwash ileitis in about 10% of cases. So this one you should have in mind. Opposites attract, but similarities bind. It can be again related to sex or the personalities. There are many stories about cobblestones, serpentine, and lead pipes. So here again, in contrast to the earlier pseudopolyps, I find that it is being literally carpeted with multiple polyps, which is producing a classical cobblestone appearance. That is because of the ulceration in between, so that the rest stands above. A cobblestone appearance. And in between them, I do find a serpentine ulcer, which is classical of the Crohn's disease. This particular one, an intestine is an organ that collapses when you lift. But here, the pathologist is having some difficulty in trying to expose the mucosa by retracting the wall. And look at the thickness, this is not normal. So you find that it is more or less rigid, and we call it a lead pipe rigidity. This is more well maintained in this case. You look at the thickness, and incidentally, I find that there is a cobblestone appearance in the mucosa, which can be made out here also. So lead pipes, serpentine ulcers, cobblestones. Have it in mind. As I told you earlier, whenever there is a gross difference, there will be microscopic differences. And think of the subheadings. The subheadings will definitely take you to the answer. Basal plasmacytosis, architecture, distortion of the crypts, atrophy of the crypts, villiform mucosa, presence or absence of granuloma, and lymphoid aggregates. These things we shall appear. Actually, this particular chart that has been given in the recent advance has got 8 columns, which I have summarized to 4. And it is not difficult. You find that all these characters are found in chronic inflammatory bowel disease, and the normal architecture is retained in a case of inflammatory colitis or infective colitis. And these are the other features you people can go through. By heart the tabular columns, they will save us a lot of time. And again, in the histology, there can be basal giant cells, Paneth cell metaplasia, crypt abscess, as in the case of chronic inflammatory bowel disease, mucin depletion. These are some characters. And these are the abbreviations that have been given through. IC is for infective colitis, CA for chronic inflammation, CABD, inflammatory bowel disease, of course, and UC is ulcerative colitis. So try to go through these features alone. The rest of it, whether you recollect or not, doesn't matter. So again, the story of the villus standing above the surface, lined by the columnar cells of the goblet cells, functional leading to mucus secretion. Lower down, you find that there is a lot of potential for multiplication as well as the differentiation. So you have got what is called as the Paneth cells, the stem cells, the goblet cells again superficially, enteroendocrine cells, and some tuft cells. So these are the things. So whenever such a biopsy is there for us, we should identify the changes or know what changes are there in a case of malabsorption, inflammation, infection, or IBD. Crohn's disease, again, not much of a repetition. you find that there is an epithelioid granuloma, preferably lower down, non-necrotizing. There can be minimal giant cells. And whenever we think of tuberculosis, it can be the other way around. No necrosis, deep down, lower down in the GIT. This again is important. We all know that Crohn's disease can affect anywhere from the anal canal up to the oral cavity, from the GIT to the extra intestinal structures. Whatever be it, you find that the manifestations are more in the lower GIT. There is a transmural inflammation, fissuring, and etc. can be seen. Sometimes there is a granulomatous appendicitis, which can of course be seen even in a case of introbius vermicularis, vasculitis, and so on. So you find that there is an occurrence in a younger patient. This is our friend, the classical crypt abscess. Thanks to this wonderful artist, I shall be going back to it. You find that there are the neutrophils over here forming a crypt abscess, or sometimes they do surround the crypts, which lead to cryptitis. This is a beautiful diagram. I shall not be repeating the other things except these two. WNT, which is a wingless related integration site. So this is important for the differentiation or the transformation into the different types of cells. Secondly, you find that there is a bone morphogenetic protein, which I did not know what it was. Why should a BMP come in the intestine? In fact, it is considered to be essential for the gastrointestinal tract. So these are the various cells. Have these in mind. In one, I find that there is a gradual decrease in the WNT, wingless related integration site, whereas in another, I find that there is a progressive increase as we go higher. What are the morphological changes? So one, you find that there is a fission or a fissure. So there is a kind of fusion or an addition that happens over here. And there can be the broadening of the crypts, after which there is a buckling. There are different types of cells, go back to them. But then you see that there is a buckling, just as you see an infolding in a case of a glandular hyperplasia. And it folds much inside. So it can be due to pressure from the tissue. Also, you find that there can be a growth pressure, as well as you find that there is a reproduction leading to an outpouch that is possible. So there is a branching crypt which can be there. So all these morphological changes, fission, buckling, infolding, then the outpouching, as well as the branching of the crypts, you people shall and will write. Now, what about the appendix and chronic inflammatory bowel disease? It is important because this can be part of a chronic inflammatory bowel disease. However, when we do get a specimen of an appendix, we concentrate more on acute appendicitis, subacute appendicitis, or a chronic recurrent appendicitis. But seldom do we realize that it can be part of an inflammatory bowel disease. Having said that, when we do an appendicectomy, we are inadvertently trying to cure the disease, because the appendix itself is the source of this antigen antibody reaction, and inflammatory bowel disease is itself an immunological disorder according to one school of thought. So having done an appendicectomy, you are partly curing the inflammatory bowel disease. But then when there are going to be something like skip lesions, appendix can be considered. And also you find that there can be a florid lymphocytic infiltration in a case of ulcerative colitis. And where is the appendix after all located? It is in the cecum, it is in the large intestine. There are other causes also. Fecal stasis can lead to both ulcerative colitis as well as appendicitis. Diverticulitis and ulcerative colitis. Granuloma I have already mentioned. So look at this particular picture. It is a case of appendicitis, and then there is a myxoid degeneration. This myxoid degeneration, they say, can be associated with ulcerative colitis or another form of chronic inflammatory bowel disease. So are we really right in giving our diagnosis on appendicitis? Think about it. And when we do a colonoscopy, as well as the appendix visualization, we find that there can be the broad villi that can be present. And there is also an inflammatory infiltrate which is becoming diffuse. We do give a report of a chronic active colitis, which again can indicate marked inflammation. We will have to look for this architectural distortion. Look at this particular area where there is a branching of the, there is an atrophy of the villi. There can be erosion in some areas, which I am seeing, and no granuloma is seen. So both ulcerative colitis and other infective causes are open. Look at the panel of differential diagnosis. You people can go through them. I'll go to the picture straight. And this incidentally is an endoscopic picture showing large pale areas. And this is the biopsy of it. And there is a pale eosinophilic acellular area in the region of the submucosa, which happens to be amyloidosis. Controversies in the East and West. When you people go to an examination of lab or otherwise, and you say, what are the causes of granuloma? That's a question asked. You say tuberculosis. The examiners will immediately say that that has been eradicated long back. Why don't you say something common like, say, the Crohn's disease, which is very common over there, and we do find it. So granulomatous diseases. This, however, is a classical case of tuberculosis with the formation of strictures, and there is a granuloma as well. Only thing, giant cells, and if you find necrosis and a history of tuberculosis, you are lucky. Pseudomembranous colitis is one, caused by Clostridium difficile. And I find that the pale superficial ulcers with a greenish exudate can be there. The crypt architectural changes will be there, which are very mild, much less than in Crohn's disease. So this can be a DD. Another one is a colitis over here. Multiple buttonhole elevations are, and they are minute ulcers. Lower down, of course, that can be the classical flask-shaped ulcer, which is indicative of amoebic colitis. Here again, as I told you, there is a malabsorption. So you find that there is a broadening of the villi over here. There is a blunting of the villi, and the crypts also become shallow. There is an inflammatory infiltrate that can be seen through. The patient can be presenting with various malabsorption manifestations, classical of celiac disease. That having been said, there is also another school of thought from thanks to gastroenterology over here, the journal from which it is taken. You find that celiac disease and inflammatory bowel disease can be two different spectrums. There are various genes that are there, and then the gluten sensitive enteropathy is over here, whereas the microbes, diet, etc., environmental factors can be towards inflammatory bowel disease. Diagnosis. I think it's an undergraduate slide which people will be teaching. So it is an abdominal actinomycosis. If you go to the first chapter in Robbins, you would have mentioned the different causes of granulomata, of which actinomycosis can be one. Necrotizing granuloma, recall syphilis, recall actinomycosis, recall tuberculosis. The macroscopic picture is extremely important, the endoscopic biopsy, and it should be correlated with the other things. Apart from that, when you do an endoscopy, a biopsy, a photograph should be taken so that it becomes a permanent record. And you also see the macroscopic differences between Crohn's disease and ulcerative colitis. Even before the biopsy is seen, you people should have all these details on your desk. So this is the classical string sign that is there. So you find that there will be a lead pipe rigidity, there can be narrowing. There are again alternate areas of normal bowel. As a result of which, when you give an alternate contrast X-ray, you find that there will be an area of narrowing called the string sign. One thing it can be prone for will be the formation of a fistula. This we have already explained to you people, the classical process. And that is it. So you can very well appreciate the rigidity in this one. Feel the texture. So I would like you people to kindly do the match fixing in this case. So I'm able to see this one, and probably there's a string sign, and there is a thickening, there is a hose pipe rigidity. And also the creeping fat over the intestine can be appreciated very much in this diagram. I would like you people to kindly acknowledge Avindita Noori, who happened to be a medical student in Malaysia. Now she must be a faculty elsewhere. And the superb sketches that she has drawn are worth visiting. Thanks to her. In Crohn's disease, you find that there can be the skip lesion, there can be a transmural inflammation, whereas in an ulcerative colitis, there can be the tags of pseudopolyps. Very beautifully depicted. And this diagram, again by the same person, you find it carries the various diagnoses for the Crohn's disease, for ulcerative colitis, and some of the differential diagnoses such as diverticulitis. Patient could have been on medication or radiation. Kindly roll them on. So this is a typical backwash ileitis that has been drawn in a case of ulcerative colitis. Granuloma we have seen, and this is a branching crypt. There is also an area of superficial ulceration, dense scuffing by lymphocytes and plasma cells. So this is a normal mucosa, and here I am finding that there is a loss of the crypt and there can be the branching. Also, you find there is something called as metastatic Crohn's disease, which means there can be granulomatous lesions elsewhere in the body, which should not deviate from a diagnosis of Crohn's. Have it in mind. There is a scoring system called as Gibber's score, in which he identifies 6 different types. So one, it is quiescent, almost normal, but there is slight abnormality. In another one, there is a single focus of inflammation. Cryptitis can be there. In the third one, you find that there are multiple regions of inflammation which could be made out, whereas it is diffuse cryptitis in a case of D. So the crypt is getting involved. Also, I find that there is an erosion in this particular region, which is F. And finally, you find that there is an extensive ulceration with severe colitis. So this is the Gibber's score, which you people shall mention. Not required, only for recapitulation, cobblestone and creeping fiber. And here again, half and half. That is exactly what is classical of this Crohn's disease. You find that skip lesion, I thought only one longitudinal region will be involved and other longitudinal free. But look at this particular one. One half on the left is involved, whereas the other half appears near normal or totally normal. Half and half, that is how it has been termed by the radiologist. And this is the carpet of pebbles. So this is the inflammation that is transmitted. As I mentioned earlier, granulomata can be seen elsewhere. This is a vulvar biopsy in the case of Crohn's disease, displaying the epithelioid granule. Wonderful diagram. Sometimes black is beautiful. Look at the black and white. I think it is able to give me a better picture of the cryptitis, inflammation of the epithelial cells by the neutrophils, and also the formation of the crypt abscess, which is again made out over here. Also, there can be atrophy of the crypts. It is not going deep down, and what I should appreciate in this particular picture will be this. I am able to find the plasma cells, the eosinophils, the mast cells, and the lymphocytes lower. So base of the crypt inflammation is important in a diagnosis of chronic inflammatory bowel disease. Neoplasia, there are certain neoplasia that have been mentioned, and I would like you people to kindly visit my class on the serrated lesions from the recent advances, also your other books. So colorectal carcinoma, more in a case of chronic inflammatory bowel disease, much more in ulcerative colitis. You will have to look for the duration of the disease, the extent to which it is, and any other chromosomal instability, such as microsomal instability, we will have to look for. Younger age group is affected in this, and there is also a group called the Lynch syndrome, which is predisposing to chronic inflammatory bowel disease and then the malignancy thereof. So these are the details of the Lynch syndrome. You people will be seeing it elsewhere. A lot of malignancies, colon, endometrium, bile duct, etc. can be caused, but CEO can be your mnemonic. Remember at least colorectal, endometrial, and ovarian. This, as I told you earlier, remember only the subheadings. Forget the numbers, it is sheer madness. You people cannot recollect, nor can I. But there is a category of, say, inflammatory bowel related and then colorectal carcinoma. So there is a colorectal carcinoma over here, and then there can be the same, which can be related to inflammatory bowel disease. What are the clinical features? What are the pathological features? Clinical is the age, whether it is multiple, which side it is, etc. Whereas the pathology is whether it has got a crown-like features, mucin secretion is there. If there is a neoplasia, is it well differentiated? Do you find signet ring cells or the medullary type of tumor? Look at this. It is a mucinous adenocarcinoma. There are tumor cells in lakes or a sea of mucin, which is classical of the ulcerative colitis. There are also other tumors such as the pouch cancer, which is rare. It can occur at the anal junction, anorectal junction, or in the regions of iliorectal anastomosis. There is a crown-like reaction that can be seen. Forgive me for the spelling mistake. Lymphoma also is another tumor that can develop, but it is very rare. It is suggested but not supported. Immunosuppression is supposed to be one of the predisposing conditions, Epstein-Barr virus. And large cell B-cell lymphoma is the tumor over here. Another tumor will be the appendiceal neoplasm, which can be a cystadenoma or a neuroendocrine tumor. Appendiceal cystadenoma is 15 times more common. And you find in a case of chronic inflammatory bowel disease, you find it is 8 times more common in the appendix. Neuroendocrine is the same as elsewhere. Dysplastic colorectum is one. A study has been conducted to prevent the carcinoma. It has been done by the British Society of Gastroenterology, wherein they do a colonoscopy, take a biopsy, localize the site, and then resort to what is called as targeted biopsy. And in this condition of dysplasia, you find that it resembles a dysplastic adenoma. So these are the 4 tumors you people will have to remember. One is a colorectal carcinoma, second is a pouch cancer, third one is lymphoma, 4 is any appendiceal neoplasm, and 5 is dysplastic colorectal. These are the key points given as a summary. I would like you people to kindly go through these subheadings. Think of the subheadings will take you to the answer. Also, the serrated polyp is another university question for us. It is a wonderfully narrated one in one of the recent advances. I have taken a class on it, which shall be available in class. So I would like you people to kindly revisit them. They are all university questions for them, very intricately related to each other. And these are the things that you will have to. What is IBD? What are the provisions for diagnosis? What is the correlation? What are the morphological features, microscopic features? What can be the predictors or suspicious features? Then granulomatous lesion, the differential diagnosis, what happens in the crypt? What is the esophageal pathology, the role of the appendix, etc. A life without cause is a life without effect. I hope I'm doing something for you. Thank you, my dear students.